Hey guys, today we're starting with chapter 27, the GI system. And first off, we're going to look at the functions of the digestive tract, and that includes ingestion, digestion, absorption of nutrients, and elimination of waste. Four functions of the digestive tract. Let's go over the structures. The main and the accessory structures of the digestive tract include, with main structures, we have the mouth, the pharynx, the esophagus, the stomach, the small intestine, the large intestine, and the anus. And then the accessory structures include the salivary glands, the liver, the gallbladder, and the pancreas. And this is a visual. Not getting the bottom here. Let me work on my positioning here. There we go. So in our diagram here, we can see, excuse me, we see the mouth, the pharynx, the esophagus, move down to the stomach, and then we have the small intestine. The large intestine includes, well, let's look at the small intestine first. The small intestines includes the duodenum, the jejunum. I don't think we have a picture of the jejunum. Jejunum and the ileum. And that is the small intestine. And then the large intestine includes the cecum, the ascending colon, the transverse colon, the descending colon, the sigmoid colon, the rectum, and the anus. Well, we did not have the jejunum or the ileum listed. The jejunum is in this area, and the ileum is over in this area. All right, let's look at the age-related changes in the GI system. The teeth are mechanically worn down. And this leads to problems with digestion because the patients aren't chewing their food completely. The muscles for swallowing become weaker and less coordinated. And that leads to patients, unfortunately, choking more easily. So they're at a greater risk as they age. They have a significant, oops, let me skip one. The esophageal sphincter becomes less efficient. So you're going to see a lot of problems in your geriatric population with GERD. There's a significant loss of taste buds with age. The production of hydrochloric acid and digestive enzymes decrease with age. Gastric motor activity slows. And this leads to diminished motility in the large intestine and to go back to a significant loss of taste buds with age. This has a significant impact on a patient's nutritional status. A lot of your geriatric patients are anorexic, have anorexia. They don't have an appetite, and they do find it much more difficult to eat with the loss of taste buds. So as you can see, with the impact of aging on a patient's digestive system, we can see where there are potential problems nutritionally for our elder patient. This slide shows some GI terms you need to know. We have absorption, peristalsis, metabolism, analysis, and catabolism. You will see these again. Diagnostic tests. There are several. You have a table on page 630 through 635. The GI system is has a lot of content, a lot of diagnostic tests that can be used. I'm going to go into specifics with the different testing in the upcoming slides. So let's look at those. This slide shows different radiographic studies of the GI system. And you can see they've used contrast media. You can see the contrast media. It helps to outline the hollow organs of the digestive tract. Now let's look at the next slide. This is a CT. And I want to look at the CT and then compare it with our next video slide, which is an MRI, to show you the difference in CT versus MRI. And we can see here a lot of different looking things going on in the abdominal tract. You can make out the liver here, and we see on this CT there's a lot of clotting going on, a lot of thrombus. We can make out some issues there. There's multiple liver abscesses. So a lot of clots in this patient's CT. It's very difficult in the CT to identify abnormal tissue. So let's compare this CT with an MRI. Now this is a picture of an MRI, and you can see the liver up here, and you can see some very abnormal, it's really cool, you can see the kidney right there, and the other kidney over here. You see the liver here, but something very abnormal. You can even see vessels. Isn't that cool? But this right here is very abnormal. It should not be there. If you haven't already noticed, that is a tumor. So you can see with the MRI that it provides a better view of the contrast between normal and pathologic tissue. Much better picture in your MRIs. I want to talk about prepping patients for diagnostic procedures of the GI tract. This picture here shows a colonoscopy, and there's a lot of prep for diagnostic procedures. Usually a patient prep for upper GI or a lower GI involves bowel prep. And so we have to keep in mind that we're putting elderly patients at risk when we do any type of diagnostic, because they have to be NPO, and they have to prep for the procedure itself. Usually this requires drinking some type of prep solution or using special solutions so that when they get in there, the bowel's all cleaned out. What I want you to be aware of is that patients who, especially your geriatric patients who are prepping for diagnostic procedures of the GI system, are at risk for dehydration, and metabolic acidosis. So what you want to implement for patients who are who are having some type of bowel prep for diagnostic is they're gonna you want to be sure that when they return from their diagnostic that they're finished with their pictures. Um, and then you want to give them a snack and something to drink. You want to get them started as soon as it's possible. Clarify your orders, make sure they're finished with their procedure. They don't have to have any second part before you feed them, of course. And you see a normal colostomy there, or excuse me, not colostomy, colonoscopy there. You see a small polyp beginning here, and then this is a polyp that they're going to remove. Laboratory studies include gastric analysis, occult blood test, and stool examination. I'm going to look specifically at stool examination. When you collect stool samples to send off, you want to deliver the stool samples. Best practice is deliver them immediately to the laboratory, but that's not always possible. So let's go through the steps of bowel procedure, stool collecting procedure. So you're going to collect the specimen in a clean, dry container. We want to try not to have any urine in the container. It will destroy any parasites that are in the stool. We don't want to put bathroom tissue into the stool sample. It also can change and interfere with the test. Again, it's best to deliver the stool samples immediately to the laboratory, but that's not always possible. So when temporary storage is necessary, you want to understand what your specimen is being collected for. Specimens for ova and parasites, we want to keep warm, and specimens for pathogens, we want to refrigerate. When a stool sample is being tested for occult blood, you want to make sure the patient has not eaten any red meat for 2 to 3 days before the test. It can interfere with the results. There are some medications that can interfere with the results, such as salicylates, ascorbic acid, anticoagulant agents, and steroids. If there is visible blood in or mucus in the stool, you want to go ahead and just send that with the sample. Page 636, your book starts talking about collecting your data, looking at your health history, the patient's chief complaint, their medical history, a review of their body systems, what is their functional assessment, and then doing your head to toe. So look over that information. I'm going to talk about some specific points. This is a picture out of your book, page 636, and it's showing you how to osculate bowel sounds in the 4 quads. And we've already went over this. We did this the first or second week of school, where we learned the head to toe assessment before we went to clinical. So we'll cover this on testing for GI. Know that normal bowel sounds, you're going to hear gurgles or clicks, about 5 to 30 in a minute. We state that bowel sounds are hypoactive when we hear no bowel sounds for 30 seconds in each quad. So we have a decreased amount of gurgles or clicks with hypoactive. Hyperactive is more frequent than gurgles or clicks. You just hear a hyperactive, a lot of activity, so it's more often than every 5 to 30. And hyperactive bowel sounds are present when the patient has diarrhea, or you're going to hear hyperactive right after they have eaten a meal. And then absent bowel sounds can be documented. The standard of care is listening to each quad for 5 minutes. You don't hear any bowel sounds, we can document absent. Common problems in the GI system that we can encounter with disorders. We're going to cover those here. And this includes anorexia, nausea and vomiting, accumulation of flatus, constipation, and diarrhea. You have patient teaching on page 640 about how to reduce gas and bloating in your patients. I want you to look over that. That's important information. This is a problem we deal with a lot with our patients, especially those who have just had surgery. All right, let's look at some of these others. Other common problems of the GI system. First up, we have anorexia, and this can occur in patients when they have poorly fitting dentures, or mouth disorders, or some type of mouth pain, or nausea, decreased sense of taste or smell, which comes with aging. So this is a common problem with your geriatric patients. And then there's some medications that actually affect the patient's appetite. Their physical and social environment, especially at meal times, have a lot to do with their appetite. So we want to keep that in mind. And then emotional problems, anxiety, depression, patients who have disturbing thoughts can also affect their appetite. And anorexia, by the way, is basically an absence of appetite. And so we've just talked about several physical causes of diminished appetite. Again, with our elder patients, their taste and smell diminish with age. So elderly persons may also, that affect their appetite. So elderly persons may also have lost teeth because of dental disease, and that makes eating more difficult for them. Their dental plates, as they age, may begin to fit incorrectly, and that can make eating a problem. And then polypharmacy is a frequent cause of anorexia in elderly patients. Medical treatment for anorexia, we want to identify and correct the cause, and then treat it. Sometimes there's no physical cause found for anorexia, and so we want to implement as many measures as possible for the patient if we can't find a cause. And of course, the doctor will order nutritional supplements for this patient. Nursing responsibilities, we want to implement oral hygiene before and after meals. It'd be good to get their mouth clean, brush their teeth, maybe even use some mouthwash, get a nice clean mouth before and after meals. Teach proper oral hygiene for your patients. Make sure they are implementing appropriate care. And if they have any issues with their teeth, we need to refer to a dentist. It's important to make sure if a patient has a problem with nausea that we give them their medicine before it's mealtime. And you want to make sure the environment in the room is conducive to mealtime. So you want to kind of remove any bedpans or MSS basins, and just make the environment more conducive to eating. Socialization is important during mealtime, and so we can implement socialization depending on the facility. They can go to the dining hall, or we can invite family members to come and bring dishes from home. This can sometimes help the patient. Of course, make sure that they're following their diet order with any meals brought in. And it's important to understand their patient's likes and dislikes so that when they get their meal tray, if they're not eating it, we can call and get them another tray. Positioning during mealtime is important. We want the patient to be comfortable and have access to their food and their drink. And lastly, and most importantly, don't rush the patient even though you're in a hurry. Let the patient take their time eating. Nausea and vomiting is a common issue that we deal with for the GI system. Nausea is referred to as queasiness, and then vomiting is the forceful expulsion of stomach contents through the mouth. Complications include loss of fluid and electrolytes with vomiting and aspiration. Medical treatment, we can get orders for antiemetics. We can hydrate the patient with IV fluids. If a patient's nausea, their oral fluids are going to be limited, and sometimes they're going to be placed NPO, give the gut a rest. They may have an NG tube. Your book talks about, on page 639, complementary alternative therapies such as ginger for nausea. Some nursing interventions to implement for the patient with nausea and vomiting that has imbalanced nutrition and or deficient fluid volume when a patient isn't eating and drinking enough. So these are the implementations for nursing responsibility. You want to assist the patient in the correct positioning for eating, maintain a cool temperature in the room, and of course make it conducive to eating. You want to remove any unpleasant stimuli. If the patient needs an emesis basin, you want to make sure you provide it. And apply a cool, damp cloth to the face and neck. This will help the discomfort. Advise the patient to take deep breaths and swallow. This can help the nausea pass. Give the medications as ordered. And antiemetics are best given before nausea occurs. So the doctor are going to have these ordered most commonly routinely. So you want to make sure you prevent nausea rather than have to treat it. Risk for aspiration. We want to implement measures by positioning the patient on their side if we think they're going to throw up. This helps prevent aspiration. We should always have suction at the bedside for patients who are at risk for aspiration in case they aspirate and get choked. And monitor the patient's respiratory status. This is very important, especially if the patient has thrown up and you are concerned they may have aspirated. You monitor their respiratory status, and if they did aspirate, they're going to start showing some abnormal data, some abnormal symptoms. And of course, notify the physician when you assess a patient has had a change in their respiratory status, such as increasing respiratory rate, dyspnea, abnormal breath sounds. That's what you're going to see when a patient has aspirated. You're going to see a change in their vital signs, their respiratory status. They may be doing a lot of coughing and having trouble breathing. And you may hear abnormal breath sounds. Measures to help stimulate intake on your patients. You'll see this again. Moisten the patient's mouth. You want to do oral care. You want to put away bedpans and urinals. Make the room conducive to mealtime. We want to make sure the patient is getting foods they like, so they will eat them, because they're not going to eat foods they don't like. You want to encourage socialization by having the family come in and bring meals. Again, the meals need to be appropriate to the patient's diet. But having them bring in home meals and come in and eat with the patient will encourage the patient to increase their intake. Also note the fit of the patient's dentures to make sure that's not an issue. If it is, we need to refer the patient to a dentist. And again, allow the patient plenty of time to eat. These are measures that stimulate intake. Talking about nausea and given antiemetic medications, you need to be aware of the common side effect of antiemetic medication, which is it can cause drowsiness. It has effects on the central nervous system and can cause dizziness and confusion. So this places your patient, well, let's look at the next slide. Because of this common side effect of antiemetic medications, what does this place your patient at risk for? And that would be falling. So we need to implement safety precautions when a patient is taking any medications that affect their central nervous system, make them drowsy or dizzy. Our next disorder is constipation. Constipation occurs when there's hard, dry, infrequent stool. Patients pass them with difficulty. You may note hypoactive bowel sounds with constipation. Constipation is caused by diseases of the colon or rectum, as well as brain or spinal cord injuries, and this can occur after abdominal surgery. It can also occur when patients frequently ignore the urge to defecate or they use laxatives and enemas. Frequently, they become dependent on laxatives and enemas to have a bowel movement. Patients who don't have any regular exercise are at a greater risk. Not drinking enough water, eating too low fiber in your diet, or having high intake of cheese, lean meats, or pasta all lead to constipation. And then there are drugs that slow intestinal mobility and increase urine output, so that puts the patient at greater risk for constipation. Complications for patients who have constipation include the Valsalva maneuver, and that is when there's rapid changes of blood flow. When a patient is trying, it can be fatal to a patient. It can cause bradycardia, and this happens when a patient is constipated and is bearing down to try to have a bowel movement, Valsalva maneuver. They believe actually this is what caused the death of Elvis. Also, with constipation, the patient can experience hemorrhoids, and then there's fecal impaction. I want to talk about just a minute fecal impaction. When you experience this in clinical, you want to be sure of what you're dealing with. You may think a patient has diarrhea, but actually what they have is fecal impaction, and that's because the impaction will not allow any solid stool to pass, but it does allow liquid stool to pass. So you'll think your patient may be having diarrhea when actually what they have is a fecal impaction. The only way to know is number one, when was their last bowel movement, and number two, doing a rectal exam to check for a fecal impaction. And this is just where you glove and lubricate your finger. And I would highly suggest you double glove anytime you're checking for fecal impaction. And so you're going to insert your finger and assess for any impaction, any stool in the rectum. Medical treatment includes laxatives, suppositories, enemas, or a combination of all of those to help the patient have a relief. And these patients need to be placed on stool softeners and make sure they understand to drink adequate fluids with their stool softeners so that they work. Nursing interventions to implement, you want to make sure the patient's diet and fluids and exercise are maintained and that they have regular toileting habits. Oh, here's my fecal impaction. I got a little ahead of myself. Oh, I didn't mention remove impaction following your agency's policy. Next up, we have patient teaching to promote bowel health. So we want to teach our patients to include high fiber foods such as fruits. I don't have the page number where this is. I'm sorry. That's what I was looking for. Include bulk high fiber foods such as fruits or raw vegetables, greens, and whole grains in the diet. It's important to drink adequate amounts of fluid, 2,500 mLs a day, and that's of water, not monster drinks or soda. Now, if the patient has restricted fluid intake, then 2,500 mLs may be contraindicated. So you want to know what your patient's orders are. It's best if they exercise daily. It doesn't have to be a strenuous workout. Just walking for patients is excellent exercise. We want to teach them to go to the bathroom promptly in response to the urge to have a bowel movement. Ignoring the urge can cause, excuse me, ignoring the urge can cause constipation. And you want to keep in mind that the number of bowel movements a patient has is individualized to that patient. Some patients do not have a bowel movement every day. They may have a bowel movement every 2 to 3 days. So you want to assess a patient's normal bowel elimination pattern. That way you can set goals appropriately to the patient's, and it can be individualized to the patient. You'll see this again, measures to prevent constipation. You want to add whole grain cereal, so add bulk fiber foods into your diet, into the patient's diet, I should say. Have them eat fresh vegetables. They should stop laxative use if they're dependent to have a bowel movement by excuse me, using laxatives. That becomes a vicious circle. So we want to stop using laxatives and help the patient get back on a normal elimination pattern. Interestingly enough, it is a measure to prevent constipation to quit using laxatives, but it's also an intervention for constipation. So it can be a vicious circle if the patient becomes dependent on laxative use to have a bowel movement. So we want to be monitoring and assessing for that. And of course, adequate fluid intake is vital. You want to be sure you understand patients' disease processes, because they may have an order for restricting fluids. Regular exercise is important, and then keeping the patient on a regular bowel elimination pattern for them. Next up, we have diarrhea. Diarrhea is the passage of loose liquid stool with increased frequency. Patients may experience cramps, abdominal pain, hyperactive bowel sounds, and a feeling of urgency before bowel movements with diarrhea. If diarrhea persists more than 24 to 48 hours, treatment should start. We can categorize diarrhea as mild, moderate, or severe. And note that foods that thicken stool include applesauce, pretzels, bananas, white rice, white toast, or yogurt. So these would be good selections for patients with diarrhea. want to go back and talk about diarrhea treatment. Now, if a patient has mild, and that's diarrhea less than 24 hours, that doesn't really need any, we don't implement treatment for mild diarrhea for less than 24 hours. If the patient is determined to have moderate diarrhea, so 24 to 48 hours of diarrhea, then we're going to implement a clear liquid diet. And then for severe diarrhea, when the patient has had diarrhea longer than a few days, then the doctor may order the patient to be NPO, to rest the gut completely. And just back up to moderate, clear liquids would include anything that you can see through, such as broth, apple juice, jello, tea, anything you can see through. Causes, there's a variety of things that can cause diarrhea. Illness, food poisoning, excessive stress, bowel inflammation, and then complications of diarrhea can be dehydration. And when a patient has diarrhea and becomes dehydrated, they have electrolyte imbalances. They can go into metabolic acidosis. And what you're going to see is fatigue and hypotension in your patient. So when a patient has diarrhea and they become dehydrated, you will assess fatigue and hypotension. Of course, malnutrition and anemia can occur with long-term diarrhea. Medical treatment, we want to rest the digestive tract and give antidiarrheals. If a patient has severe persistent diarrhea, the patient may require the administration of TPN, which is a nutritional fluid in which the patient has an IV and is receiving nutrition through their IV. Just looking at the nursing diagnosis diarrhea, a goal we would want to implement for a patient with diarrhea would be patient will return to normal elimination pattern, and we would assess that by assessing to see if the patient's elimination pattern has returned to normal. Nursing diagnosis for the patient with diarrhea include deficient fluid volume, and so we want to be monitoring for patients to have a hypovolemia signs and symptoms with fluid volume deficit. So you're going to go back to hypovolemia signs and symptoms and be assessing for those.